Good morning, ladies and gentlemen. Welcome BMS Symposium, Luspertercept in beta thalassemia major real-life experience. I am Amar Lal, hematologist, oncologist, Tamam Hospital in UAE. So in next 20 minutes, I will take you 4 steps. First, burden of the disease, then treatment challenges and goals. Third, pivotal phase 3 belief study, and then most important thing, real life experience of our part of the world. And final question, how do you predict thalassemia major in 2023? Global epidemiology of beta thalassemia, you can see 56,000 infants are born annually with thalassemia. And in UAE, 3% of beta thalassemia carrier rate was reported in premortal screening. Nearly 18,000 of the people, 0.230 1,000 live birth is expected. And so far, we have 1,000 reported thalassemia patients. What is goal of therapy in beta thalassemia major? Goal is cure, of course. If not possible, then go to control, continuity, quality of life, care of end organ, cost-effective, and combo of treatment. Goal is transfusion therapy to reach appropriate goal and avoidance of adverse reaction. In patients with transfusion-dependent iron overload is the key driver of the morbidity. It is accumulated by primary iron overload because of infective erythropoiesis and secondary iron overload because of the transfusion. So we have iron chelation agent to handle this problem, but still we have issue. The challenges of blood transfusion is over there. You can see this is worldwide. 25,000 transfusion-dependent children born annually. Out of this, only 3,000 have access to blood transfusion, and unfortunately, 88% patient died within 4 years as without transfusion. In our region, 50% are receiving inadequate and dropped blood transfusion as well, and they feel also difficulty in searching continuity for family friends to donate the blood as well. So if you see blood transfusion, there is some advantage and disadvantage. Advantage is suppress the infective erythropoiesis, thus limiting the pathophysiological complication and improve the lifelong term survival. As it is seen here is improving the survival, but at the cost of required every 2 to 4 weeks and risk of course, infection, alloimmunization, and most important thing is iron overload. For iron overload, we have iron chelation. Long-term, they improve the end organs, liver and heart. We have oral formulation as well, but again, at the cost of all these are not effective to all patients. And of course, you have to monitor every 3 monthly ferritin and MRI yearly, poor adherence and the high cost. And this is the level, normal level should be this one, cardiac and hepatic should be more than 20 and 6.3. And if it is mild to moderate, then it is intermediate, which is warning for potential cardiac and liver toxicity. And if it is severe, then it is the high risk of liver and hepatic toxicity. Now, to solve this problem, we have novel agents which are going through. First novel agent, ruxolitinib, actually they showed failure in inhibiting any benefit, and other is sotatercept and luspertercept. So luspertercept is actually the first and only erythroid maturing agent that has shown benefit. We go shortly. Understanding these novel agents, first we should know the erythropoiesis. This is normal erythropoiesis, which is 2 steps. First is by proliferation of progenitor cell, which is promoted by the EPO, and second is characterized by the differentiation and maturation, which is regulated by TGF-beta ligands. Now, what happens in beta thalassemia? Actually, this characterized by the expansion of early erythroid precursors. This is, you can see here, this is less, this is more here. And this characterized by the accelerated differentiation. You can see this is a normal, this is ineffective, accelerated differentiation. What happened and end result is like, you can say, you cannot take, this is the normal erythroid maturation, and this erythroid maturation is affected, and this is called, we call it the ineffective erythropoiesis. So we have to handle this ineffective erythropoiesis, and this is all because of accumulation of TGF beta ligands. Now we have target the TGF beta ligands, which is called luspatercept, which is the recombinant fuel protein. This is actually luspatercept. What happens, this, these are yellow, are the TGF factor superfamily. They take out this from here and they diminish the signaling, the path, and they cause from ineffective erythropoiesis, which was I showed here before. Now it become effective erythropoiesis from erythroid maturation, which was like this. Now it become like this one. Erythroid maturation become better, and this lead from ineffective to effective erythropoiesis with the help of the luspatercept. Now, we have actually development of phase 1 to phase 3. Different medications are ongoing, but here you can see only phase 3 is the luspatercept and FDA approved so far we have. Phase 3 trial of luspatercept in patients with a transfusion dependent, which was published in New England Journal in 2020. This is actually a double-blind randomized pivotal trial, 2-to-1, more than 300 patients. 1 year is the double blind. After 1 year, the patient can cross over that called the open label. So I will show you the result. The primary endpoint was actually to response to see 33% reduction in transfusion within 3 months. So this is the primary endpoint. Here you can say 33% reduction of RBC transfusion was seen, about 24% of the patient. So now, if continue, even some benefit was seen up to 70%, and up to 24 weeks, 6 months, it was seen in 41% as well. A reduction of transfusion also leads from 40%, 12 weeks, and 24 weeks is 16.5%. Of course, this lead less transfusion means less iron overload. This is again endorsed by luspatercept. Ferritin level you can see is -2 to 3 as compared to placebo, which is 114. Especially it was seen, these are the curve which is called responder. You can see the responder in the serum ferritin is all the minus, and the people who are in placebo, like this one, they have higher ferritin, and it leads to again low LIC as well. So it means it affects the liver and cardiac efficacy as well. Now, BELIEVE trial has shown it met primary endpoint, statistically significant 33% reduction in RBC transfusion burden with luspatercept versus placebo plus bed-supported care, made key secondary endpoint, including 33% and 50% RBC transfusion burden reduction with the luspatercept, and also significant clinical meaningful reduction in RBC transfusion versus placebo during 12 weeks to 24 weeks. And it's generally well tolerated with primary adverse effect, including bone pain and arthralgia was noted. That's why luspatercept was approved by the FDA in November 2019, which is 4 years ago, and in EMA 3 years ago, also in June 20, it is approved. Now, where we stand, this is fourth part of my talk, actually, real life experience with luspatercept. I actually use in my patient to check whether the patient is eligible for luspatercept or not. I use a resource we call as an expert online. I show you what is the expert online. This is the actually CCO tool. Here it is 7 steps of the expert. 7 steps. First, you put whether your patient is transfusion dependent. Second thing, if their patient is stable in the transfusion dependent, any complication related to anemia, any yellow bodies, and any iron overload problem is maintained or not. A last question is patient eligible for transplant? Put these patients' data In this tool, they will answer you which treatment patient is needed. This is expert online. Now, first case, 44-year female who had actually splenectomy at the age of 18 years. She had very good compliant actually, but the problem is her hemoglobin never reached between 6 to 8, but our target was to make it 9 and 10. So she had a steady state of hemoglobin between 6 and 9, but she has a major symptom because of continuously anemia. This is not only post-splenectomy, she has also diabetes mellitus, she has pituitary insufficiency, she has adrenal insufficiency and secondary amenorrhea. Despite of all complaints, she has complex history and complications. So what should be done in next? What is the step? Now, again, the patient, here is the challenge. You see the ferritin level it is between 2000 and 2050 over the 3 to 4 years, you can say. And the challenge was here, you see hemoglobin, even if it reaches up to 5 and 6 frequently, and patient needs the transfusion. So this is the challenge of the patient. Now, I put an expert online, as I mentioned, 7 steps. What they recommend, two experts recommend 2/3 gene therapy can be taken, and 100% they recommend, and this patient is eligible for luspatercept if it is not available gene therapy. Now, in this patient, here you can see over the 1 year, the graph of the ferritin, it was 1700s, naturally lesser transfusion, lesser frequency of transfusion, a lesser number of transfusion leads to the lesser ferritin. Before, ferritin was between 1517 12 weeks before luspatercept, but over the 6 months, it was 1,000, and over the 1 year, it reaches only 600 ferritin. So this is 1 year journey of the luspatercept of our first patient. This was the, again, showing about this patient. This was the challenge in the baseline. She was taking 12 units, and then she reached with the luspatercept only 6 units, and the solution is there, 50% reduction of the transfusion. Before, hemoglobin level, I mentioned 6 to maximum 8. With the luspatercept, which reaches to 10.4, that increased to 30%. This is the burden reduction of 1 year of post-treatment and benefit of all explained over here. So this is the journey of the patient. You see, this was the whole challenge, which was seen in the graph from 2018 till 21. All the ferritin is high and hemoglobin is low. But if you see now, after 1 year journey, this is the 1 year journey of the patient, ferritin is going down and hemoglobin is never touches the 9. It's always between 10 and 11. So this is the beauty of 1 year of treatment of this patient. Now, case 2, 33-year male who's actually non-hospitalized, but the problem is patient is non-compliant. His hemoglobin is 7. Because of non-compliant, his ferritin is very high. You can take up to the 7,000. So this is the challenge, 33-year male with high ferritin burden. What should be the next? Go through the expert online. Expert online say either remove the spleen or more intensify chelation agent by infusion or pump or anything. Otherwise, you can say luspatercept. This one is expert 2. Even other expert also indicate if it's not work or the thing, luspatercept, the only things you can do in this patient. So we started actually luspatercept in this patient. This is the journey of the 9 months of the patient. Here I would want to see, this is the before, total number of units is 12, but after luspatercept 6 units. And number of RBC visit is 4, here is 3, and hemoglobin, which was 7, now reaches to 10. This is the baseline, 12 units to 6 units, and 50% reduction of the transfusion, and hemoglobin from 7 to 10 increase, 42% increase the hemoglobin. This is the curve which I pull out from my patient's graph over the 6 to 9 month journey of the ferritin. You can see here, and this is I checked here before 8,000 and 7,050, but now after, you see this is the first one is 6,000, then now is 4,000. So less requirement of the blood transfusion that leads to the less ferritin, of course. Now third case, 23-year male, Again, regular blood transfusion, the problem here is, again, the challenge was non-compliant. That lead to the high ferritin you see is 8,000 touching, and hemoglobin is also between 7 and 8 always. Now, what expert online, again, 75% they recommend the patient should take luspatercept. In this patient, it was given here, you see hemoglobin touches 6 to 7, but this is first time after 6 months of luspatercept, it touches now 10. Now we see the difference, total number of units before 14 and after luspatercept 8, and total number of RBC here 6, now 4, hemoglobin 6.5, now it is 10. So this was the challenge, the baseline you see 14 reaches to the 8 units, and hemoglobin increased from 6.5 to 10. So 42% reduction of the transfusion and 53% of the hemoglobin increase. And this is the chart, which again pull out ferritin from our 700 patient record. It was the beginning, and then after luspatercept, you can see decrease. And again, it's well explained before 7,000, 8,050. 8,500. Now it's after 3 months, 6,000, and after 6 months, again becomes 4,000 ferritin. So last 20 minutes, real world experience of luspatercept. I took you the burden, challenges, belief trial, and lifetime experience. Again, as I mentioned, the goal is cure, and then you have to control and continuity of the care. But again, the question is, do we reach in 2023 or not? Here I mentioned briefly, the cure is possible in 2023, stem cell transplant. Other thing is gene therapy, which is less hazards. You can use it, number one. And number two, otherwise you have to control with the help of blood transfusion, iron chelating agent, and of course with the luspatercept. And but final question is, how do you predict in 2023 whether thalassemia is benign or malignant? I think solution is testing, treating, and of course the team here I mentioned. Team starts from nurse specialists, hepatologists, diabetologists, endocrinologists, cardiologists, transplant specialists, and psychologists, and thalassemia physician in the center. So this is how the teamwork works, T3, to treat the patient. Now, I discuss testing, treating, and team, and this was my final take. Thank you very much. I'm here. If any question, please email us or you can ask us discussion. Thank you very much.